Welcome. I'm Greg Block, and I teach law at Georgetown. Welcome to the first event in our Georgetown Law series on the COVID crisis. We'll be addressing issues of law and policy that are posed or forced upon us by COVID. Some of these issues will involve health policy, and others arise from the devastating and sweeping social and economic impact of this disease. Our first event today will be a discussion which we've titled, Will the American Way of Healthcare Financing Survive COVID-19? We'll have future events on health disparities, racial and class disparities in both health and healthcare, and on a variety of other issues that are posed by this crisis. Chairing and moderating the discussion today will be Katie Keith. Katie covers all developments that are Affordable Care Act related for the Journal of Health Affairs, which is the preeminent health policy journal in the country. Her several times a week blog on the Health Affairs website has become must reading for the American healthcare policy community. Katie's also a scholar with Georgetown's O'Neill Institute and an independent health policy consultant. And I'm proud to say that she's a graduate of the Georgetown Johns Hopkins Joint Degree Program in Law and Public Health. And with that, I will turn things over to Katie Keith.
Thanks so much, Greg, and thanks for the warm introduction. It is my delight and honor to be with you all today, especially with such an esteemed panel to help us make sense of exactly what is going on with COVID-19 costs and what it might mean both for sort of short and medium term healthcare policy and solutions, and then what it might mean for the long term. So, who better than the folks that we have joining us today? I think to ground that conversation, I did want to just pull in a little bit of the data. Many of you joining know that there's great uncertainty about what COVID-19 costs are going to be. We don't really know sort of COVID-19 costs alone, and then there's sort of the broader market implications. What does it mean for the labor market? What does it mean for sort of provider consolidation going down the road? What does it mean for, everything that is unfolding and all of the different market dynamics that we have out there? So there are a number of different estimates out there. I wanted to throw a couple of numbers at you. Many folks have compared COVID-19 to, the incidence of flu or pneumonia. A lot of the estimates are based on hospitalization rates and ICU rates. You have numbers from organizations like Fair Health estimating that, allowed charges would be about $73,000 per COVID-19 patient who's hospitalized, with commercial insurers paying maybe $38,000 per patient. These estimates vary wildly. Wakely, in a study for America's Health Insurance Plans, estimated that costs could be up to $139 billion in 2020 alone for commercial payers, Medicare Advantage, and Medicaid managed care companies. Big numbers being thrown all over the place, lots and lots of uncertainty. At the same time, you have a lot of insurance companies on earnings calls, S&P Global doing estimates saying insurance companies are doing just fine right now. And so far, that's what we're seeing in sort of the early rates that are being filed at the state level for 2021. And so as we think about hospitals being sort of underwater in terms of financing, insurers being up, how do those dynamics change over time? Do they change, and what do they mean? And then I'll just tick off a couple of factors that I think our panelists are going to speak a lot about, but things that we should all as health policy people be paying attention to. The impact of delayed elective care, frankly, the severity and the incidence of the disease. So many of these estimates vary wildly based on how many folks we expect to ultimately be infected by COVID-19, which none of us really know the answer to. The shift to telehealth, what does that mean for healthcare prices going forward? Where are COVID-19 patients? Are they commercially insured? Are they in Medicare? Are they in Medicaid? All things that we need to pay attention to. What is the cost of a vaccine, and what does this sort of mean for market dynamics going forward? So, lots of uncertainty that we're operating in the short and medium term, and then also need to think about, to use Greg's phrase, what does this really black swan moment mean for the future of healthcare? And is this a real inflection point to maybe make some broader changes that many of us have been thinking about for a long time? So I will stop there. There's a lot of uncertainty, but we're gonna, try to make some sense of that over the next hour. And it's my delight. I'll just briefly introduce the panel and then kick things over to Greg for our sort of first opening remarks. So on the one hand, we're joined by Stephanie Woolhandler, She's a distinguished professor at the School of Urban Public Health at CUNY. She's also an esteemed co-founder of Physicians for a National Health Program. Delighted to have you here, Stephanie. I think your perspective is going to be super valuable, and what a moment to be thinking and working on the issues that you work on. We're also joined by Dan Wickler, who's the Mary B. Saltonstall Professor of Ethics and Population Health at Harvard's School of Public Health. Dan focuses on a lot of ethical issues, serves as an advisor to the WHO, an excellent perspective to sort of join in today. David Super, who's also a professor of law at Georgetown, really focuses on federal and statutory interpretation, has done a lot of work on the Medicaid program. If Congress is going to act, what do we need to know in terms of responding to this moment? And then finally, Greg Block, who, as you all have met, is a professor of law at Georgetown and focuses on all things healthcare, especially as a JD/MD. And so I will stop there, but we're very fortunate today. Greg, let me kick things over to you for just some opening remarks.
All righty, and each of us will, at this point, offer just a couple minutes of opening remarks. And I want to make 2 points. First, there's the immediate challenge of how we pay for the cost of COVID. And there are 2 stories being told right now, and they seem to contradict each other, but I submit that they don't. One of the stories is that health insurers and employers are enjoying a windfall from all the non-urgent care that's being deferred. And some, like Zeke Emanuel, have argued that health insurers at least ought to pony up right now and help struggling primary care practices and other struggling healthcare providers survive what's been a devastating short-term economic impact. Another story out there is that a coming COVID surge, and we've all seen the predictions of second waves and subsequent waves. A group headquartered at University of Minnesota has predicted a number of possible scenarios that involve multiple waves. And a coming COVID surge could impose hundreds of billions of dollars in additional costs on health insurers and employers, as well as state Medicaid programs. It has been difficult for epidemiologists to imagine other than a gradual progression in fits and starts to a point where upwards of 60% of Americans have been infected by this virus. That's the point at which we can begin to think about herd immunity. And if there's not a vaccine, then that means a progression of this virus through this country in a way that infects people and gives them the disease to the degree that we've seen thus far. And we all know the numbers. It's been estimated that perhaps there's a 5% seropositivity rate in this country. And we have about 100,000 confirmed dead. So you can do the math for what it would take to get, say, to 50% seropositivity, what the cost would be in numbers of death. So both these stories are true. It's a matter of the time frame we focus on. In the immediate term, there's a windfall for insurers. Over the next 18 months to 2 years, there's a huge burden that seems to loom for all who pay for healthcare. There are also huge uncertainties, and Americans, of course, don't like uncertainty. We plainly don't like to plan for it. We've demonstrated that. But 40 to 70% of Americans or more becoming infected. Estimates, and Katie Keith referred to these, estimates that range from $20-something thousand per hospitalized case to $70,000 plus per hospitalized case. All of these numbers would appear to add up to hundreds of billions of dollars over the next 18 months to 2 years, whether we're talking the low hundreds or the high hundreds of billions of dollars to the point of more, perhaps even more than $1 trillion in excess cost. We don't know. Dan Wickler and I have proposed in a recent Health Affairs blog piece a loan guarantee program to protect both health insurers and employers from going under if this surge happens. And part of our vision is that we don't bail them out unless this is not a preemptory bailout. This is a plan to rescue institutions that would have a devastating impact on the health economy, certainly on hospitals and healthcare providers if they lost their ability to pay for healthcare. The second point I wanted to get at is the opportunity here for a reframing of our national debate over universal coverage. For several generations, our battles over universal coverage, or lack thereof, have centered on what we do or don't owe the least well off amongst us. The assumption since the antibiotics revolution has been that illness is something that affects individuals and families, and healthcare is something that benefits individuals, not whole societies. And I submit that COVID is an opportunity for us to reframe our understanding of healthcare's role, for us to connect back with an older vision of health as something that, if not dealt with for some amongst us, has devastating effects on the rest of us. And we certainly see that dramatically with infectious disease. I remember when I was in medical school, there was this presumption that, with the exception of the HIV epidemic, we had basically conquered infectious disease. And obviously, that assumption has come back to bite us hard. And so older ideas about gaining control of infectious disease are now relevant, and older ideas about denying healthcare to some, having devastating implications for the rest of us, are critically relevant. And I think there's more of an opportunity for progressives than progressives have seized upon thus far to reframe the discussion about universal coverage in terms of protecting everybody, rather than only doing something for the least advantaged amongst us. However important we believe that doing something for the least advantaged amongst us is.
Thanks, Greg. That was terrific, and I think a perfect jumping off point for Stephanie. I neglected my most important job, however, which was to encourage the audience, if you do have questions, to please drop those in the Q&A function. I think it's at the bottom of your screen, but we'd love to take your questions, and we'll be turning to those sort of towards the end of the conversation. But please do send those questions. And Stephanie, over to you.
Okay, well, I mean, the first question here is, are health insurers in any trouble at all? And, you know, it does appear that they are immune to COVID-19. This is a quote from Moody's. The industry, according to our estimates, could have a net benefit. Okay, so they clearly are benefiting right now. We can ask, are they going to continue benefiting? And I would just point out the reason they're benefiting is there's been such a big fall off of the expensive elective procedures. And that's more than offset the increased costs from COVID. And should we get another surge of COVID cases in the fall, as we probably will, none of us know, but we probably will, they'll be in the same position again. They'll have higher COVID costs, but a big drop in their elective procedures. Now, this is not just my prediction. This is actually the prediction of the market, right? And people who play the market think that the market is good. It's the wisdom of the crowd. You may think the market is the madness of the crowd, at least in some cases. But the market, Wall Street, apparently thinks insurers are going to do very well. And they're way ahead of the S&P 500. They're only 1% below their average in January 2020. So doing much better than the rest of the market. So wisdom of the crowd, madness of the crowd, predicting the future says they're going to continue doing well. I think the bigger question is, do we care if they're in trouble? Because not every industry that's in trouble deserves to be saved. I don't see people saying we're going to have a big government expenditure to bail out small retail shops that are being eaten up by Amazon and online retailing. The decision's been made that's not worth saving. I think we as a society need to be making the decision about whether private insurance was worth saving if they did get in trouble. And this would be my main argument about why they're not. Private insurance wastes a huge amount of our health spending. Looking here at the private Medicare Advantage plans, their overhead is 14% versus 2% traditional Medicare. So a much more rational thing to do would be to get rid of the insurance industry, to let them go under, if that in fact is what's going to happen, and to switch to a Medicare for all system, as was advocated by two major presidential candidates. They're not going to be in the general election, unfortunately, unless perhaps a vice president. But I think that's really on the table still. Should we be moving to that Medicare for all system to save that money on administration? And I would add, though, I'm not going to go into it today, that the seeking profits by the insurance company, their profit-seeking behavior disorganizes the rest of the healthcare system. And by the way, this is a disclosure, I guess I am also a physician. I practice in the South Bronx. I actually teach medicine at Harvard Medical School, where I was until recently a professor of medicine. So who's in trouble, who's not, okay? Looking at the job losses in the time between mid-March and mid-April, insurers basically had no job loss all the way over on the right. But if you look all the way over on the left, ambulatory care, doctor's offices, dentist offices are in deep financial trouble. And that's why there's been about 1.4 million people laid off in the healthcare system in the past month. So doctor's offices, particularly small institutions and doctor's offices, are in very deep financial trouble. Article in Undark, the journalism review, to stay afloat pandemic, doctors' offices turned to GoFundMe. Literally, doctors' offices in this country are going bankrupt. They're going to GoFundMe campaigns to get people to donate so they can pay their rent, so they can keep their staff online and on the payroll. And small doctors' offices are literally about to go under in this country. And again, we would ask, should they be saved? And in fact, the general public says they like small doctors' offices better than big institutions. That's a different question, I guess. Now, who else is in trouble? It turns out that a lot of the American people are in very, very deep trouble and in need of a bailout. And we all know that unemployment has gone up by 15%. 15% of the labor force has lost their job. And depending on what kind of model you use, it does seem that by the end of this calendar quarter, by June 30th, we're going to have at least 43 million Americans, more than at any time or equal to any time since 1976. So American people in deep trouble and in need of help paying their medical costs. The other way the American people are in deep trouble is a longer standing problem with the crisis in health in the United States. And looking at life expectancy growth since 1960, with the US compared to other comparably wealthy nations, the United States more or less kept up with the rest of the world till about 1980. But you'll see beginning about 1980, the US fell off the curve. Life expectancy started to increase much more slowly in the US than anywhere else. And since 2015, life expectancy has actually fallen in the United States in 3 out of the past 4 years. So the health of the American people is in fact in trouble. Okay, so let me turn it over to Dan, I guess.
Yeah, I think we'll kick things to David next.
Oh, sorry about that.
No, you're good.
Dan won't be last.
Thank you very much. I will be brief to leave time for the Q&A and discussion. The Medicaid program has rested for its life on several assumptions, and this crisis is destabilizing pretty much all of them. One was federalism, that we could have a lot of the cost paid for by the states. The massive financial crisis, the fact that state sales tax revenues have fallen off a cliff, that income tax withholding for states has fallen off a cliff, and that states are, at last report, looking at a $765 billion shortfall in 2020, 2021, and 2022, suggests that the states simply are not a reliable source of funding for Medicaid. Great during a boom, but people need health care, boom or bust. And we've seen certainly signs of this in the Great Recession, and we're seeing it even more fervently now. The Congress has done a very miserly job of increasing the matching rate for Medicaid. I hope that next month they will do better by that. But I think that the state financial role in Medicaid now needs to be very closely re-examined. We're simply not able to make it stick. Second, the notion of Medicaid was in part to replace a bunch of haphazard institution-based responses to healthcare. And now that we find ourselves in a crisis, we're retreating to those with the inefficiencies and, frankly, chaos that you might expect. We've got Medicaid, but we've got hospital bailouts, and we've got funds for the uninsured, and they're being administered by a bunch of different agencies, and some of them are flowing and some of them are jammed up, and some of them are missing, many of them are missing out on some of the healthcare providers that people value most, as was just mentioned, and that need to survive. So our diffidence about insurance for low-income people, I think, is coming back to get us. A third aspect of Medicaid that has been there for most of its history is a very peculiar notion of moral virtue, that we would cover the elderly and the children and the people with disabilities and ultra low income parents of children, maybe sometimes a little bit, but that lots of society would be deemed unworthy for it, that they could fend for themselves. And the consequence of having so many uninsured people in society drove us to pass the Affordable Care Act, but then the Supreme Court clipped its wings by allowing states to opt out of Medicaid expansion. And one of the sets of hospitals that are among the most endangered are rural hospitals in states that didn't expand Medicaid. Many of them closed even before the crisis, and more are likely going to be knocked down now, which means that people will be farther and farther from an emergency room or a hospital. And even after we get beyond the point now where it's very difficult to visit people in the hospital, people may have to be hospitalized so far from their homes that they can't effectively be visited. I think this notion that we can parse the population on individual worth rather than look at societal impacts is getting badly undermined. If also the fierce individualism we're seeing in pushing back against public health restrictions results in surges of infection, which I fear it will, in the areas that are most resistant to the social distancing guidance, that I think that may undermine some of the individualistic arguments that stood up for restricting Medicaid. For all of these reasons, I think Medicaid as a model is going to have to be reevaluated, not necessarily because one has progressive ideas, but because its bedrock assumptions are teetering and on the verge of collapse.
Thanks, David, and over to you, Dan.
Thank you. So let me begin by saying all of the above, and now I'll try to add a couple of new ideas, although I'm really just going to reframe some of the ones we've already heard. it's been noted by a number of decision scientists that Homo sapiens seem to have big problems with imagining exponential growth. We know what a rising curve is, but we don't know what exponential means. And that's why we have someone like the President of the United States doodling about whether or not he wants to add 260 cruise ship people to his number without realizing that in a couple of weeks, the numbers are going to be explosively greater. And I'm sure all of us agree that the people who are instigating those protesters, who are bringing machine guns down to talk about their rights of assembly, they're playing with fire, because these people and the people they live with are in grave jeopardy. And when that happens, they'll be enormously surprised. It's partly this inability to just deal with what exponential growth looks like when you've got an infectious agent like the COVID-19. Now, we all know that, but it seems to me that there's something comparable when it comes to not just incidence, but also the cost of care. There can be explosive exponential growth in caring for people who've unfortunately succumbed to the virus. The proposal that Greg and I put forth is a backstop to the private health insurance system, not one that either of us, I think, is particularly fond of at all, but it's the one we have. And so it's a moral matter. If those who have some training and can sort of look ahead and grasp what exponential growth looks like, both in incidence and also in cost of care, we can focus on the absolute need to make sure that there's a system that's going to kick in with very, very low latency, and just kick in immediately, so that when droves of people present themselves to already beset hospitals and clinics, if they're still open, and say we absolutely need care, that the lack of a financing mechanism is not going to be a reason to refuse them care. And that's what we propose. So it only kicks in when that happens, but the risk that it's going to happen is so great that it would be terribly irresponsible if we didn't have something like that prepared and ready to go almost instantaneously. Now, Steffi asked, well, why not let the private health insurance system go under? They have very few fans apart from their shareholders. Well, the reason, of course, is that letting them go under imperils care to people who have an urgent need for it. They can't sit around and say, okay, well, we'll wait until Congress responds appropriately and passes a decent universal care plan. They're going to be in big, big trouble immediately, and something has to be done. So with the proposal that Greg and I put forth, basically the government is going to be stepping up to the plate and saying we're the reinsurer of last resort. When everything else fails, when the ledgers turn from looking great for the insurance companies to looking grim, rather than deny care to anybody, the government will start providing financing, but it can impose conditions, and those conditions are conditions that we should be thinking about right now. The conditions having to do with everything from who has access to the care that is being paid for, but also things like limitations on executive compensation and financial engineering, like buybacks and all that stuff. It's a loan program. Those loans are not going to be forgiven if any of those rules are violated, according to the plan that we put forth. And what you get in the end, when the dust settles, if it ever does, might be something that looks like the kind of single payer plan that Steffi has courageously been advocating for decades. And with many of the properties that we would have achieved if we had somehow won legislative victories that have so far eluded us. So my hope is that the plan that Greg and I are proposing would not be needed, because it will only be needed in extremis. But if it should happen to be needed, it's important that it be there. And the only silver lining that could possibly brighten the picture a little bit is that what we might have is something pretty close to where we want to be at the end of it all. Thanks.
This is excellent, thank you. So I have a few questions, and then we're already getting some excellent audience questions as well. I think many of you talked about sort of the need, or just the reality, frankly, of shifting a lot of the costs to the federal government, whether that's in the Medicaid context through increased FMAPs or a transition. Steffi, sort of a much broader overhaul, or Greg and Dan, your concept of sort of low interest loan guarantees to private issuers. The HEROES Act included a one-sided risk corridors program. You know, there's a lot of these sort of different ideas of how do you inject federal money to stabilize the system. The other argument that I've seen coming up a lot from the insurance companies is sort of the role of the public health system. And so I also wanted to kind of get your take on that. And as we're drawing lines of, you know, we're going to need to do sort of surveillance testing. We have typically thought of that as a public health function, if you will, where people need a test maybe to go back to work. They need a test maybe multiple times a year. You already have insurance companies complaining about the high costs that that's going to bring, especially if they're not sort of effectively negotiating with the labs. And there's this sort of division of, well, that's a public health function. That is not healthcare financing. That's something that everyone needs. How do you sort of grapple with this in the programs that you think about? What do you think of that distinction? Should we be drawing that line? Is it a fair distinction? Maybe whoever wants to take that. But how are we shifting on the public health framework on the financing side as well?
Okay, just briefly.
So you mentioned a public health system. What system was that?
Okay.
Enough said.
Okay, a couple of things. First of all, in the places that I'm familiar with, the South Bronx in New York, Cambridge Hospital, we had exponential growth in April. We had the entire hospitals full of COVID patients. The hospitals were still getting less in revenue than they were 2 months ago, which means the insurers were paying them less than they were paid 2 months ago. So we've had experience with exponential growth. When COVID grows exponentially, the hospital revenues actually go down, which means insurance companies are paying less, or insurers in general. We also have models like Medicare. But getting back to the health, I do teach public health these days. And, you know, the public health spending has been dropping in the United States. It's only about 2.5% of health spending in the United States. In Canada, public health spending, 6% of health spending. And we've seen a fall in public health spending. And the way it's a system is, in fact, most of the money comes from the federal government, flows through the CDC, and then to the public health departments in states and counties. So even though there's lots of different authorities and jurisdictions, the main flow of funding actually does come from the federal government, which has been cutting and cutting and cutting. And there's been a profound shrinkage in the workforce. The frontline public health workforce is 20% smaller than it was a decade and a half ago. There's profound demoralization, I think. I mean, the Centers for Disease Control, we probably all used to thinking of them as some sort of zenith of intellectual integrity and wisdom. And they've made a mess of this. And I don't know what's happened at the CDC, but something very demoralizing and very bad has been happening there in terms of their ability to speak out, to lead. So yes, the failure of public health in this country is massive. I don't think insurers can pick that up. Frankly, I don't think Medicare or Medicaid could pick it up. I think that's just a decision by the American people, by the federal government, to put the kind of money into public health to rebuild the public health infrastructure here.
Yeah, great, go ahead.
Yeah, so a couple of thoughts about your really important question. First, and also I think about some important points that Steffi has spotlit. First of all, of course, we need a massive infusion of well-targeted resources into the public health space. And hopefully that will be part of this reframing of medical and health need that is urgent. In the meantime, though, there's an opportunity, although I wouldn't expect this administration to take it, perhaps the next administration, if God save us on that first Tuesday in November, will come in. There may well be, and I'd be interested in David's thoughts about this as well, there may well be opportunities to look at flexibilities in the Affordable Care Act. There is some rather vague language that defines preventive care. And that language defining preventive care could perhaps be interpreted to incorporate a variety of public health expenditures, including perhaps surveillance testing. I wonder if it could even incorporate contact tracing. I don't know. I have not looked at the statutory language and reflected on this. But perhaps there's room within the existing ACA structure to mandate first dollar coverage for a variety of functions that previously had been dismissed as quote unquote public health and not medical care. Another thing I want to flag here is something that simply hasn't been discussed in the public space by journalists, by political leaders, or by health economists. And that is, why is it that we have a health economy which is paying for these so-called elective or non-urgent procedures at a high premium, rather like airlines do great when they sell first-class airline seats, but is paying hospitals at rates that lose money for intensive care unit and other services of the sort that are being called upon in the COVID crisis. And I ask that not as a rhetorical question, but as a real question. I know a little bit about hospital pricing and cross-subsidization structures and why hospitals do what they do, but I don't know enough to have an explanation. And I would like to see journalists and health economists and others asking that central question, a question of pricing that will be critical to the ability of our healthcare institutions and our small doctor's offices to survive over the next 18 months to 2 years. Last thing I wanted to say briefly, by way of, I think, reinforcing some of what Dan said about our proposal for backstop of loan guarantees. A huge part of our private system of payment involves not insurance companies, but employers that pay for their own employees' health care. Georgetown University, who's funding this platform, is an example of that. So Georgetown University, in all probability, enjoyed a great windfall over the last couple months, several months, for the reasons that Steffi pointed to. But Georgetown University, especially given all the economic pressures on Georgetown, the loss of a bunch of sources of revenue, same kinds of economic pressures that are on most going concerns, for-profit and not-for-profit in America, Georgetown University is facing a huge threat in the event that there is a large COVID second or third wave. And employers in general are facing a threat at a time when they're trying to, get up off the floor from another Great Recession or a second depression. And so creating a safety net for them is, I would argue, at least as important as some safety net for insurers for the purpose of making sure that providers will get paid.
Just to respond to a couple of those points, I don't think we're going to make real progress if we maintain the highly individualized, individualistic framing for all of this. A bit of public health spending can be smuggled into individual coverage in the manner that Greg talks about. A lot of it probably can't. If this is going to teach us anything as a country, I hope it is that we are vastly more interconnected than we were in the fabled pioneer days, when in fact we were plenty interconnected but refused to remember that. That we need to find ways of finding secure funding for things like public health that are not tied to one individual's health insurance. That is a problem with the federal budget system, in that, with the rarest of exceptions, the programs with the most secure funding are individually based programs, so-called entitlements or direct spending. And we need to adapt that system to provide secure funding for things that serve us all rather than any one of us. And I hope we will now understand how foolish it is to neglect that.
Should we go to some of our questions?
Can I just make enter one big scale thought? Stephanie is completely right in asking why is it that CDC has had to put up with constantly lower budgets? It's crazy. Similarly, we can ask why are the homeless not, you know, that we can solve the homelessness problem for at a cost that's quite reasonable. Why haven't we done that? And so on with every one of these programs that's not an individual entitlement. Why is it? Well, we know why it is. It's because there's been an assault on the, you know, the entire system to leech every program that has general value slowly, so that it's not immediately visible. But we now see the cumulative impact of this. And of course, we realize in the case of a pandemic that it's all related, that if you're homeless, you can't protect yourself and all the rest of it. And now we're in a big pickle. But nevertheless, it's been an overwhelming assault on the system. And unless something can be done to reverse that tide, it's going to keep happening.
Thanks, Dan. So we are getting some excellent questions. I'm going to put a couple of these together. So for folks who care about universal health coverage, what is sort of something we could do quickly that could be adopted kind of in response to the crisis that we have in front of us? And maybe perhaps a more provocative idea, because insurance companies are doing so well right now, should we be using that as a tool and maybe as a place for people to go? So what are some quick ways and quick solutions on universal health coverage? And more or less, what is the role of insurers in that push?
Well, the federal government has to pay for this anyway. So they could just say everybody lost their job, gets put on Medicare. They could say we're combining the costs of the uninsured Medicare and Medicaid and just paying doctors directly during the crisis. That moves us a whole lot closer to Medicare for all than funneling the money through the insurance industry, letting them take their 13% overhead off the top to pay for their profits and buildings and bureaucracy, and then hoping that the rest of that, 87% of that trickles down to the people who need it. So there's lots of stuff out there. You know, if you want to start paying some of these doctors primary care doctors and outpatient doctors whose practices are financially collapsing, we have the model of the National Health Service Corps, where the federal government just picks up the salaries of doctors who are willing to take all comers. So there's lots of models out there. We do not have to stick with our private for-profit insurance model. In fact, we're the only nation on earth that relies so heavily on these private for-profit insurance models, and we would have a much more efficient system and a much fairer system if we took the federal revenues and siphoned them through a fairer and less administratively top-heavy way of paying for care.
Other reactions?
I think.
Look, I hate to disagree with stuff because I agree with you completely. Question is, what's the likelihood of this happening given the current alignment of political forces?
I don't know. They came up with $100 billion for hospitals overnight. They came up with a $600 a week add-on to unemployment benefits overnight. Lots of things that just sounded totally impossible 2 months ago became possible under COVID. So this opportunity for those of us, like the people in this room who, at this call, who are obviously sitting going, well, we have this huge problem. We have 43 million uninsured. We have these horrible death rates. We have unfairness. We have a hospital system that does this elective surgery, whether people need it or not, but ignores pressing needs like substance use, mental health, primary care. We can solve that with models that exist. And now, people are thinking big right now. And it's time for us to be thinking big as well.
Yeah, Greg, go ahead.
Yeah, just briefly, I think it is useful by analogy to how some of our great jurists have thought about legal progress over the long haul to think about path dependence. And it's an iconic idea amongst generations of law students and legal scholars, for instance, that Thurgood Marshall brought our legal system, including the Supreme Court, to the point of desegregation through a winding, wending path. A winding, wending path that didn't bring about a revolution, although we nowadays think of Brown v. Board as a revolutionary moment, but his brilliance, and some have analogized Ruth Bader Ginsburg to Thurgood Marshall in this regard. Their brilliance, many now believe, was a consequence of how they found a difficult path, a path through high mountains that looked for kind of local passes and local streams to make it across. And I think that a problem that a lot of single-payer advocates, however, who are very, of course, well-meaning, run into is that they want to kind of plow ahead and let's use the dynamite to blast through those mountains. We're going to bring about this revolution. Now, the COVID crisis presents all sorts of opportunities to reframe, but it's probably not going to allow for a series of nuclear blasts that get you through the Rocky Mountains while traveling at sea level. And looking for pathways to the broader vision that you're seeking may be more effective both at getting there and at reducing the chance that there's going to be the kind of ferocious backlash that we've sometimes seen with big social policy moves forward. So that, for instance, a public option which is well supported by the federal government and which is opt-out rather than opt-in, so that everybody is signed up, but somebody can sign up for switch to a private plan, or somebody can opt out. That solves the Justice Roberts Commerce Clause problem, I would think. David could comment on that more wisely than I. And that moves things in, I think, a lot of the direction, in the direction that Steffi and others are talking about, and yet there's a steam valve at the same time. People who say, no, hell no, I won't go, those folks can say, okay, I'll sign up for my more expensive private plan, more expensive because it has the administrative costs Steffi mentioned, and it has not been able to negotiate as good a deal with various providers. But you get there, you know, you have to climb some mountain passes. You can't do it with kind of, you know, nukes that blast through the Rockies.
Okay, I don't think of myself as using nukes, but I do find that polls show that the majority of the American people support Medicare for all. You are probably aware of those polls. So saying the majority of the people support Medicare for all, but it's impossible to do it. Wait a minute. That's actually saying you're giving up a democracy. That the fact that people want it, they still can't get it. So I don't think you're meaning to, but you're coming down on the side that say the moneyed interests now, the private insurance industry and the private pharmaceutical industry that benefit from the way things are, they're so powerful that democracy can't work in this country. And I don't think that's true.
Take a look at some of the, some of those polls also ask the question of whether people want to keep their private insurance. And there's a surprising double-digit percentage of folks in the kind of low to mid double digits of people who somehow think that they can have both Medicare for all and their private insurance at the same time. I'm reminded a bit of that infamous line, I don't want the federal government messing with my Medicare. So there's a lot of
that's not my interpretation of the polls in general. In general, if you tell people they can keep their doctor and see any doctor they want, as is true in existing Medicare. This is not pie in the sky. Existing Medicare, there's no referrals. You got any doctor you want. So if you tell people you're gonna be able to go to your doctor in the hospital you want, they don't seem to mind losing the private insurance industry. People can conflate private insurance with private doctors, and that's why you get the kind of results you're talking about. But
the conflation creates all sorts of opportunities for folks to come in with promotional campaigns, advertising. We all remember Harry and Louise. And so that's part of what I'm worried about. Let's give the system an escape clause. But Katie.
So let me, continuing on that thread a little bit, getting into the politics. I think pre-COVID, high healthcare costs, which I think is a major barrier to universal health coverage, right, were a hot topic. At the state level, at the federal level, you had bipartisan pushes, at least moving forward on prescription drug pricing, on surprise medical billing. There's been a lot of activity at the state level on public options in particular. And then, this really animated, I think, the Democratic primary. All of that to me is focused on cost containment, and highly imperfect as it is, trying to get healthcare costs down. Given that we're in such a different moment, we haven't seen any of those types of proposals included in these big, massive $3 to $4 trillion bills, to Stephanie's point. What does sort of the moment that we're in, what prospects do you give the future of cost containment, or are hospitals, so to pick on them, are they so underwater that we're not going to be able to actually get to the policy making of healthcare costs for a while? Would just love to hear your thoughts on that.
Well, we've had a very curious asymmetry in how these bills are constructed. The Democrats have scrupulously insisted that all provisions be temporary, whereas Republicans have proposed permanent capital gains tax cuts, permanent changing to expenses, expensing restaurant meals, and all manner of things. If you keep that principle going, which I don't understand, then no, we're not going to make any permanent changes here at all. There is a point, I don't know that we're there now, but by the winter perhaps we will be, where we are far enough into the crisis that we actually know some things. We actually know how badly our current healthcare financing system has failed us, how hopeless it is to patch it together with duct tape. And it may become possible to draw some judgments as about how to move forward. I certainly hope that those will be judgments, as I've said, that are less individualistic and more aware of our common dependence on one another, and the fact that you are uninsured is a problem for me as well as for you. I don't think we'll get there until we are late in the crisis, but it would be unfortunate if we let all of these horrendously expensive lessons that we've learned in terms of humans' lives and our society pass without acting on them, which we've done on a number of occasions in the past. We didn't do anything after Hurricane Katrina, and we didn't do very much permanent after the Great Recession.
We're all aware of the cute saying, never waste a crisis. When there's a crisis, you have to respond to the immediate urgent need. And if you're really clever, you can put forth a solution that's going to help you and your people in the long run. And it will be deemed accessible because there's a crisis, whereas otherwise it'd be totally rejected. Now, we know there are a lot of people playing this game right now. I think those of us who are concerned about restoring the public health system and having a universal and national approach to health and to health insurance should be playing the same game. And that's the spirit in which Greg and I were offering our proposal.
Should we go to some more of our questions?
Certainly. So some folks are sort of interested, given what is an increasingly clear link between private health insurance and your employer. That has long been sort of a third rail in terms of policymaking. It's something that the ACA did a very light touch to, in part because of the Harry and Louise ads. It's already being used, I think, to push against some of the more progressive policy proposals on the Democratic side right now. Do any of you sort of see a shift? Is there a moment that we're approaching where it feels like the time where you could actually untether or tether less the private health insurance system to employment? Maybe Greg, go ahead. You got your hand up first.
Yeah. Well, Could you imagine if we had a robust public option right now? And we don't know how many people have lost their jobs. There's something like 38 or 39 million who have applied in the last several weeks for unemployment benefits. The unemployment rate, for lots of reasons, is a metric that probably grossly underplays the number of unemployed folks. Could you imagine if all those folks, or not all, but a large number of the folks who have lost their jobs, say 30 some million, could then immediately gain health insurance via the public option? And what that would do in terms of the desirability, if you're a hospital or any other provider, the desirability of making a deal with the public plan and accepting a discounted rate, and what that would do in turn for the public options costs, and therefore its appeal to other people. You can imagine a kind of snowball or avalanche. I mean, this is what the private insurance industry most fears. This is why they made sure that Senator Joe Lieberman, back when the ACA was being debated, stood firm against the public option. It wasn't just Lieberman, there were others as well on the Democratic side. But could you imagine if we had a public option in place right now, what that shift would be? And I submit that would be the kind of sea change that our questioners, through Katie's translation of the questions, that's the shift that our questioners have in mind. Talk about wasting a crisis as an opportunity. We're doing that right now because there's not a public option, let alone a robust public option on the books.
See, I think that's a misunderstanding of how public option works, because public option is something that's offered on the exchanges by and large, and means if you have money in your pocket to go buy private insurance on the exchange, you could instead use that money in your pocket to buy Medicare or a Medicare-like program on the exchange. Most people say just offering a public option without pouring in a huge amount of funding to make it free is only minimally going to increase the number of people with coverage. So I don't oppose a public option, but simply offering a public option for sale on the Obamacare exchanges covers a couple of million people at most, and also you don't get your administrative savings that you get out of a single payer.
Let me underscore, I'm talking about an opt-out. I'm talking about an opt-out public option so that people can be placed in that plan after they're unemployed for, say, X number of days or weeks. And I'm also talking about a subsidy structure that is compassionate and decent, and also self-interested, because those of us who were not the worst off are at risk when people are off of their insurance and can't get care. That's, I think, the message that several of us, including David and Dan, are trying to drive home. But I'm talking about a generous public option that doesn't put people in the circumstances that you're talking about. And then if somebody, say one of those folks who likes to dress in camo with an AR-15 and go to the Michigan State Legislature wants to opt out of having health care, then, let him.
It's, how many people really opt out of Medicare? There are people who have still working and their employer will pay their insurance, but most people turn 65, they're pretty glad about it, even if they're wearing camo. Now, that's not just because they have Medicare as an option, but Medicare is an option that the government's paying for, right? And that's the difference between Medicare for all and public option. Even I think you're talking about the Medicare Extra or the Medicare Part E proposal, right? Yeah, it's extreme public option, but people are still paying premiums, co-payments, deductibles, and that kind of system. You've still got private insurance with all of their overhead and billing costs, so you can't capture that money to expand care. So, we could have a debate about public option, but it's not Medicare for all. It's not as affordable, and it's not as comprehensive in terms of getting everyone covered.
I think it's worth mentioning, responding to Katie's question, that the employer employment-based health system for insurance was under severe attack before the COVID thing. If you've read the Case and Deaton Deaths of Despair book, the work employment linked health insurance turns out to be a major villain in the piece, very unexpectedly. They give a very powerful reason to abandon the thing as soon as possible.
And we're having right now a bipartisan recognition that making private employment more expensive is a really bad idea. We are shifting the cost of unemployment compensation from employers to the government overwhelmingly. The administration is adamant on what I think is, in isolation, a foolish notion of cutting the payroll tax in this particular crisis, but it suggests an understanding that we should not be jacking up the costs of getting a job. And that's what the private employment-based health insurance model does. A tax-based system makes jobs cheaper and presumably more plentiful.
Worth also spotlighting that to the extent that our income tax system, as opposed to our premium system, is financing healthcare, whatever we call it, whether we call it a public option or Medicare for all, or whether we talk about the private insurance system, to the extent that it's a premium-based system, it is a much more economically, financially regressive system. If you are, say, earning an income of $75,000 and you are a subscriber to an employment-based plan that say is pretty frugal. Let's say it's a Kaiser HMO plan out on the West Coast. You are almost certainly paying a much higher proportion of your income to cover your health insurance, especially if you count both the employer's contribution, which is part of your compensation package, and your own. You're paying a much higher percentage of your income for health insurance than if you're bringing home, say, $500,000 a year with a very generous health insurance plan that still is not going to cost that much more. So, imagine, say a $75,000 a year income versus a $750,000 a year income. Let's figure the person with a $750,000 a year income is getting a more generous health plan. It's not more generous by times 10. And so therefore, that person's paying a much lower percentage of his or her income to health insurance. So the health insurance premium system is exceptionally regressive in how it pays for healthcare.
So that's perfect because Greg, you got the last word and you gave us a math. So that's a perfect way to end this very lively discussion. Thank you so much. I think this was one of the best, most interactive discussions I've seen using this format and on a very, very important topic. I know we're a little bit after time. Greg, any closing words or want to?
Can I just actually, I'd like to encourage those who've asked questions that we haven't addressed to email us, and we'll do our best to try to get back to you. So our apologies for not getting to everybody. I guess we're too long-winded a group here. But thanks so much to Katie as our wonderful moderator, and to Steffi, and to David, and to Dan for your contributions. And we'll all be following this closely as this painful story unfolds.
Stay well, everyone. Goodbye.
Thanks, everyone.
Bye-bye.